Just when you thought that you had enough of me after my initial discussion of the topics related to CPR, I'm sorry that I have to come back and haunt you again. This is the second part of my talk, which is primarily related to the remaining topics in the cardiac and hemodynamic management of the critically ill patient. I will deal dominantly with fluids, both the nature of the fluids and the rate of infusion of the fluids. I will deal with some issues related to hemodynamic monitoring. There have not been any major developments in this area, but I will focus on a couple of issues. In the cardiac aspect of it, I will focus on the importance of angiography and intervention in cardiogenic shock. And I will discuss one paper that is related to the use of inotropes in cardiogenic shock. That will be the course of the next half an hour or so. Okay. So with that as the background, let me just start off with the primary concern about fluid resuscitation. As we already are very familiar, a lot of our attention in the last decade or so has been shifted towards the underuse of balanced salt solutions. We recognize that normal saline is not something that is physiologically appropriate. And when we use normal saline in contrast to the balanced salt solutions, we do produce a greater amount of acid-base perturbations and potentially renal injury in most of these patients. But unfortunately, despite this physiological understanding, it is not translated into any kind of a very clear improvement in terms of outcomes. And the best data that we have in relation to this has been the study called the SMART study. It is very important. There are large numbers of studies on not so critically ill patients, and there have been small randomized controlled trials, which give us outcomes that are not necessarily the best of our outcomes that in this area. But I think we need to look at the SMART study primarily because it dealt dominantly with critical care adults in our ICUs. And it had a large sample size of almost 15,000 odd patients. It was a multi-center study from 5 academic intensive care units. And it was done in a very different way. It was a cluster randomized trial with crossovers. I will not go into the discussion of the methodology, but I can promise you that this has got a much more robust methodology than the standard individual patient randomization. Okay. The unfortunate problem with this is, despite the fact that they had such a large number of patients, and despite the fact that they didn't look very specifically at an endpoint like mortality, but they used a composite endpoint, what is called the major adverse kidney event, which included not only mortality, but also included the development of renal replacement therapy or persistent renal dysfunction. Despite that, the statistical significance in this trial was at best marginal. And I just did a calculation of the fragility index, that is, of this particular paper, and found that it's close to 0. There was actually no significant differences between the two groups in the study, but when they did an adjustment, they seemed to demonstrate a small significance, which unfortunately gets clearly annulled. So even though people point to the SMART study and say it is a good indicator of the value of balanced crystalloids, again, I would say that the data is still equivocal, and there is clinical equipoise as far as the use of balanced salts versus saline in critically ill adults. As a consequence, the subsequent trial, called the BASIC study, is probably equally relevant. It is an extremely large study. Again, once again, close to 11,000 patients who were recruited. In Brazilian ICUs, there were 75 ICUs, and they were actually using a 2x2 factorial design to look at a comparison between saline and the balanced salt in this situation, what is plasmolite 148. In contrast to that, they also were trying to look at the value of fast administration of fluids versus the slow administration of fluid in ICU patients. So the first component of this is this comparison between saline and plasmolite. On a 1-to-1 randomization, they roughly got about 5,000 patients in each arm of this clinical trial. And though the volume of plasmolite or saline that was given to these patients was reasonably small, a median of about 1.5 liters were given during the initial period per day, that is. And that's a reasonable amount of the fluid that you would consider for comparison. The primary endpoint in this study was 90-day survival. And they also looked at, in the secondary endpoints, the need for renal replacement, the development of KDIGO 2 renal failure, the SOFA changes, and the ventilator-free days in these patients. This was a relatively heterogeneous kind of group. About 50% of the patients were surgical patients. Only about 60% of them were hypotensive at the initial presentation, and about 40% required ventilator support. The criteria for admission were inclusion in the trial were age greater than 65 years, a mean blood pressure less than 65 or 90. Any one of the parameters is more than enough, including ventilation, renal dysfunction, liver dysfunction, and the existence of sepsis. So these are the kinds of patients, a heterogeneous kind of a group of patients that were subjected to these two fluids. And as can be anticipated from this kind of a large pragmatic trial, is the fact that there was no difference in outcomes between the use of the saline solution or the balanced salt solution. And even when they look at the secondary endpoints, with the exception of a small change in the NeuroSOFA score at 7 days, which is probably a statistical oddity, there was absolutely no differences between the two groups, trying to very clearly imply that this data seems to suggest that if there is any kind of a benefit with the use of a balanced salt solution, it is at best marginal. It is very important to look at the way in which the study was also done, because they were extremely careful about the fact that the dominant fluid that was administered during the first 7 days was the study fluid. Though there is some contamination with the use of other crystalloid solutions, it probably becomes a little bit more prominent later in the study, and that could have probably diluted some of the effects of the benefit that you could have seen from dominantly using balanced salt solution in one arm. It is also very important to recognize that before these patients were admitted into the ICU, a large number of them got these solutions that were in the other arm. So for instance, 1/3 of the saline group got greater than 1 liter of balanced salt solution in the emergency room, and about 20% of the balanced salt group got at least 1 liter or more of saline. So what they did was they did a sensitivity analysis where they excluded the patients who got large volumes of these alternate resuscitation fluids, and they were still unable to show that there was any difference between the two groups. So in broadly, we'd probably come to the conclusion that there is no benefit of the selection of the kind of fluid in the use in the ICU. Now, there is a very important issue that we need to look at. Whenever we talk about the use of maintenance fluids or resuscitative fluids, whether they're balanced salt or normal saline, we have to understand that in the ICU, they constitute a minority of the total amount of fluids that the patient is getting. As is shown in this large retrospective study, only 6% of the total fluids per day is resuscitative, and about 1/4 of the fluids is maintenance fluid. A significant amount of fluid comes in what they call the fluid creep. The fluid creep is primarily related to a hidden unintentional volume that is administered mainly as a vehicle for medication and electrolytes. And this can contribute very significantly to the amount of chloride load that the patients can have. And this is an argument that despite your attention to appropriate selection of your balanced salt solutions, you can have a dilution of any kind of benefit by the fact that you will be using chloride-containing solutions for other purposes, and they can be quite significant. This is something that all of us should keep in mind when we are practicing it. And in general, I have a tendency to prefer to use a cheap balanced salt solution because the expensive ones are clearly not of any value. I continue to use Ringer's lactate, not exclusively, but in balance with normal saline, as long as I'm very careful about the fact that additional fluids are not given in dominantly normal saline. So this is the kind of approach. And unfortunately, this is not a great amount of data to convincingly change your treatment to using balanced salt solutions alone. The second part of the study was related to the rate of fluid resuscitation. Very typically, if you look at surviving sepsis guidelines, the management of septic critical care patients when they are admitted is usually with the recommendation a large volume of fluid, usually a 30 ml per kg, that is given as an infusion at a relatively rapid rate. Now, the benefits from this kind of resuscitation is clearly ununderstood. Likewise, when there is hemodynamic compromise, we decide to give fluid boluses at arbitrary rates. Very typically, we give 500 ml over half an hour or so. But this again is completely arbitrary and not been determined as the most effective or the necessary kind of rate that we need to use for the administration of fluids. So there is some evidence that is, and this has been rapidly growing, about the fact that when we use large volume resuscitative fluids, and this initially started with studies in children, the famous FEAST trial from much earlier in the decade seems to imply that there is an excess mortality when aggressive fluid resuscitation is attempted in patients with septic shock. And it appears that this fluid resuscitation hurts the patient not because they develop pulmonary edema or volume overload, but primarily develop a worsening cardiac failure, which is less responsive to vasopressors. And this has been shown very nicely in physiological studies where the administration of a fluid bolus, the typical 500 ml in 30 minutes, is associated with a dramatic reduction in your systemic vascular resistance or a production of a vasodilation, which necessitates an increased amount of vasopressor use. Likewise, when you look at the analysis of sepsis bundle management, and this is a large database from New York State, was completely unable to demonstrate any value of these kinds of early fluids in the resuscitation of patients. And further, this background is sort of supported by this large randomized controlled trial out of Africa, where the patients in sepsis were given 2-liter fluid boluses very rapidly, and then 2 liters over 4 hours as a continuous infusion in the short term. And what they saw was, instead of seeing an improvement in hospital mortality, they saw a dramatic increase from 33% to 48% with the rapid administration of fluids. All of this seems to imply that we need to be very careful about large volume fluid resuscitation, especially of a rapid rate. And that is the focus of the second part of the basics trial, which I said was the 2x2 factorial design. One side was the comparison between saline and plasmolite. The other side was to look at the use of fast versus slow rate. Okay. Likewise, about 10,000 odd patients were randomized. And as I told you about the sample, they're all not hypotensive patients. So all of them, you can't justify the fluid resuscitation in very large volumes. Roughly 1/2 of them were emergently admitted to the ICUs and probably were unstable patients, dominantly septic. So there is a large group of these patients who probably need aggressive resuscitation, though not all of them. Okay. In this particular part of the study, they were randomized by a blinded allocation into 2 groups, either a rapid administration group or a slow administration group. The rapid administration group was something that gave the fluid in the typical fashion of that 500 cc in half an hour, or basically they got 1 liter over an hour. The rate of infusion was set at close to 1,000 ml per hour. The machine doesn't allow 1,000, so it's given 999 ml per hour. And the slow resuscitation group was arbitrarily set at about 1/3 of that value. Okay. And the patients, remember, were not, the rate of administration was not blinded. Basically, once the patient was assigned to one group or the other, the physician provider can decide to give the fluid. And very often they stuck to the guideline. But if they felt there was a need for more rapid administration, even in the slow group, they would consider that, but try to revert to this slow administration in the large majority. Okay, please understand that the decision to do a bolus in these patients are very decided by the on-site clinician, and it is not something that has been very clearly protocolized in this particular study. And the endpoint that they looked at was a 90-day survival, with, of course, the renal function and other parameters being the secondary endpoints. Again, as anticipated, this is a large pragmatic trial with basically some patients who require fluid boluses and other patients who don't require fluid boluses. And if they're being randomized into one arm or the other, it need not necessarily mean that all of them got large fluid boluses. But anyway, when they made the comparison between these 2 arms, they were unable to demonstrate any kind of difference in survival. But if you look a little closely, you notice that there are changes in the SOFA score, the 3-day SOFA score in these patients. The deterioration in the SOFA score by greater than 2 points, particularly the cardiovascular and respiratory SOFA score, were very clearly identified in patients who were given the fast administration of fluid. And this is quite important because this is the same implication that we see from the FEAST study, which demonstrates that larger and more rapid administration of fluids ends up with a greater requirement for vasopressors, and probably in this particular situation also with a greater tendency for lung injury and pulmonary edema to develop. So in general, even though there is no statistical difference between these two, this kind of data sort of, pushes me towards greater prudence. I'd rather not flood the patients with large volumes at very high rates, but rather would use them in a far more prudent way. We do recognize that even in patients who have volume responsiveness as assessed by a dynamic test, even when they're administered large amounts of fluids, the tendency for them to retain the improvement in their blood pressure for a long period is actually quite limited. Most of these patients will ultimately require a titration of the vasopressors, and the use of large amounts of fluids are potentially not something that we need to be subjecting our patients to. Now, let me step out and look at the issues related to hemodynamic monitoring. As I said, there have been nothing dramatic in the short term, except for the tendency that we have always had of trying to use non-invasive technologies for in the place of invasive technologies, like in this situation, the measurement of arterial pressure. Very typically, either our prior choices have always been an intra-arterial line, or we would use intermittent kind of measurements of blood pressure in a non-invasive fashion. But the technology is developed towards a continuous measurement of arterial pressures with non-invasive methodology. And its evaluation in the critical care arena has been sort of limited. There are two classic technologies that are being evaluated. One is called the finger clamp, which basically is a cuff at the level of the finger that uses photoplethysmography and basically by elevating the pressures at the level of the finger cuff, it attempts to generate a continuous measurement of the arterial pressure. And the other option is what is called as applanation tonometry, where a pressure is applied on the artery and the amount of pressure that is required to flatten the artery against the bone behind it, very typically radial artery against the radius, would be a good measure of the intra-arterial pressure. And this is something that can be generated on a continuous basis. I will not discuss the technology other than the fact that these are the two broad technologies that are available. Unfortunately, when you look at the performance in the intensive care setting, the performance is extremely variable. There is a huge amount of variability that the blood pressure determined by these methods are roughly in the range of up to even 30 to 45 millimeters above and below the invasive blood pressures. And as far as the diastolic pressures are concerned, this is far greater. The distribution is significantly more. Interestingly, though other studies have looked at it, other meta-analysis, this meta-analysis tries to subgroup the patients between applanation and the finger cuff method. And they are able to demonstrate that the applanation method is probably marginally better in terms of the levels of variability. But ultimately, to draw any conclusions, the authors say that there is very low certainty of the evidence. The quality of the studies are reasonably limited. And typically, many of these studies are a large number of recordings that are done in a few patients, and their extrapolatability is going to be something that is clearly limited. At the present time, the technology of non-invasive continuous arterial pressure monitoring in the ICU is considered as experimental, and it shouldn't be used on a routine basis. The only other area that I found interesting in these analysis of hemodynamics was the value of the measurement of right ventricular function, particularly in septic ventilated patients. This paper seems to imply that if you have right ventricular dysfunction, it is an independent predictor of poor outcome. And this is not if you just see a right ventricular dilatation or the right ventricular left ventricular ratio greater than 0.6, but also if there is an associated systolic change in the right ventricular contractility as indicated by a depression in the TAPC. The combination of a low TAPC and a high RV-LV ratio is probably a good indicator of bad outcome. So when they both are combined, the cumulative survival is actually a little lower down. In this particular study, when they looked at independent predictors of 30-day mortality, it was the SOFA score, the P plateau on the ventilator, and ultimately the combination of RV-LV ratio and the decline in the TAPC. Please remember that this is only a derivation cohort. It's not something that has been tested prospectively in other cohorts, and probably something that is interesting for some of us, at least those of us who have a lot of interest in the right heart rather than the left heart. Okay, let me just go on to a more interesting area, and that is the management of cardiogenic shock. In the management of cardiogenic shock, the single revolutionary paper was in 1999, when the shock trial very clearly established that with the majority of patients in cardiogenic shock having a myocardial infarction as the primary process, revascularization of these patients is absolutely essential. Okay, at that point in time, there was a huge amount of debate. The cardiologists would always say that if you're going in and you're going to open up the vessel, you not only open up the vessel that is causing the infarct, okay, that is what you call the culprit vessel, but you try to do it for an angioplasty of other vessels also. And many cardiologists preferred multivessel angioplasty. And this is also extrapolating from stable MI, where the outcomes have been confirmed even in a recent meta-analysis that it isn't the better process to do multivessel angioplasty. But in cardiogenic shock, which is what you and I will be interested in, and where we'll have debates with our cardiologists on a regular basis, is to make it clear to the cardiologist that as much as they may have the skills in opening up all the vessels, that they shouldn't be focusing on all the vessels, and you should be focusing on the culprit vessel alone, primarily because the risk of the complex procedure in an urgent setting, like in a patient with cardiogenic shock, is likely to add to complications, in contrast to just going in, opening up the culprit vessel, and doing the rest when the patient is reasonably stable. And this is demonstrated in the famous CULPRIT shock trial, which was published close to a decade ago. In the CULPRIT shock trial, which was followed up even subsequently to 1 year, the outcome was very clearly beneficial in patients with the culprit lesion alone angioplasty, in contrast to patients who get multivessel angioplasty. And at the end of 1 year, the outcomes were exactly the same. That is, the culprit vessel group continued to show a benefit. But to cardiologists, there was another kind of a problem. Despite the fact that survival benefits were demonstrated, the patients who got the culprit vessel lesion angioplasty alone also had a greater tendency to be admitted to the hospital with congestive failure and had a greater need for subsequent coronary interventions, to the point where the cardiologist will say, why can't we identify at least a subset that will not hurt when they have cardiogenic shock? And that is the purpose of this retrospective post-hoc analysis of the CULPRIT shock trial. And basically what they saw was quite interesting in the sense that when you look at the outcomes with multivessel angioplasty and you look at the adverse outcomes related to that, it is dominantly related to the patients who have left main and proximal LAD lesions. In these patients alone, if you did a multivessel plasty, their outcomes were likely to be terrible, in contrast to virtually every other subset. In patients who have lesions in other sites, it does not matter whether you do a culprit vessel angioplasty or whether you do a multivessel angioplasty. And the implications of this are very, very clear, that in patients with left main and LAD lesions alone, it clearly says that you shouldn't be doing anything beyond the culprit vessel. But some cardiologists may extrapolate this a little bit and say, we could go ahead and consider angioplasting all the other vessels in patients who don't have this disease alone. This, unfortunately, has not been proven, but is strongly implied by this kind of analysis. The next aspect is probably what is called very aptly or inaptly, I don't know, the DOREMI trial. All of us, the immediate association with this Sound of Music. The DOREMI trial was basically related to Dobutamine as compared to Milrinone in the management of cardiogenic shock. The standard recommendations for the management of cardiogenic shock says that we should be limiting the use of inotropes only to patients who demonstrate a non-improvement in terms of the systemic perfusion, despite an attempt at normalizing the blood pressure and improving the peripheral pressures through the standard processes. In fact, the routine use is actually recommended against. It's a level 3 argument that the use of inotropic agents in most patients who are particularly asymptomatic is actually a bad process. So if there is a select use of inotropic agents, the question has always been which agent. And unfortunately, up to now, there has been no clear determination. Dobutamine, which is our typical choice, is not based on any hard data against a placebo, for instance, though it may be considered as nearly being equivalent to levosimendan, or certainly not showing you a worsened outcome in comparison to levosimendan. We don't have any real data on the value of dobutamine. Likewise, on Milrinone, which is a PDE inhibitor, has a very strong effect on pulmonary hypertension and right ventricular failure, and may be something that will enhance cardiac function to a greater extent in patients with significant pulmonary hypertension in the face of cardiogenic shock. So this clinical trial was basically an attempt to show superiority of Milrinone over dobutamine in patients with cardiogenic shock. They used this new definition, what is called the SCAI, the definitions of what is called B, C, D, and E, which is C is classic cardiogenic shock, D is decompensating, and E is basically end stage. B is what we may consider a pre-shock, that the patient is hypotensive but doesn't have perfusion defects, as the organ system failure is not yet very visible in this patient. The majority of patients in this particular trial were in the C and D groups, the classic and decompensating group. Okay, and it was dominantly based on a clinical diagnosis. They didn't always need a PA catheter to diagnose the existence of a cardiogenic shock. Okay, and though it was done in a concealed allocation, and the medication was mixed at the bedside by a concealed process, it is probably a little problematic that they used an endpoint that was a composite endpoint. The composite endpoint is quite extensive. It is not just of in-hospital death. It also looked at patients who develop a cardiac arrest, patients who have cardiac transplant, mechanical circulatory support, who have an MI, TIA, and stroke, and new renal replacement therapy. It's quite extensive. And there are a lot of problems with using such wide composite endpoints because it may not necessarily give you the best indicator of outcome, but we'll leave it at that. Okay, the size of the study was about, I claim to be about 190, for a reduction in this composite endpoint from about 55% with dobutamine to 35, or almost an absolute reduction of about 20%. I just want you to keep this in the back of your mind because I want to raise this as a concern a little later. Okay, there was a large expected decline. And unfortunately, for this kind of a large decline, you need a reasonably small number of patients. And when they did perform the study, they didn't see such a large decline. There was actually a genuine improvement of about 5% in terms of the survival with the Milrinone, and both in hospital death and in terms of the composite endpoint. But it didn't reach statistical significance because the study size itself was kept at a very low size by the miscalculation of the power of the study. So basically what it shows us is very little. We still don't know which is the inotrope of choice in patients who have cardiogenic shock, and the tendency to prefer one over the other is rather arbitrary. I just want to cross a little over the threshold at this point. I'm not going to discuss any more new papers, but I'm going to discuss what is probably something that is irking all of us. So this entire discussion, I gave you a large number of randomized controlled trials, none of which were of benefit to the patient. In fact, they all showed non-significant results. And this has been something that has been irking a lot of us, that we have a large number of negative trials, and we need to ask the reasons why this happens. Though I will say that there are a large number of reasons for this, I will explore just one specific issue related to the endpoints that we use for the measurement of outcomes in these studies. You have to remember, an outcome is always measured by some kind of an objective endpoint. And most typically, most of us in critical care would believe that the endpoint that is relevant to us is mortality. And again, we'd like to say that when we see mortality being influenced by a treatment, we should recognize that even though a treatment can be good enough to reduce the mortality significantly, there can be other covariates which can confound this reduction in mortality. And often, the ultimate result of these kinds of trials is the significance can be diluted quite a bit. And this is quite important for us to recognize. And there was a very interesting paper that looked at this some time ago. This is Scott Halpern, who did it along with his PhD student, Harry. And I've looked at the PhD the thesis itself. It's fascinating to look at it. Basically an assessment of why clinical trials are negative. But this paper showed that in about 146 clinical trials in critical care that were reviewed, 2/3 were negative. Only 1/3 was positive. And the negativity was clearly associated with the use of mortality as an endpoint. The studies which used mortality as endpoint usually were negative. 90% of them were negative. In contrast to studies that use something like an infection-related, say, microbiological cure or a clinical cure after an infection, or ventilation-related kind of parameters, which are generally much more successful. And the main reason that they feel that these mortality studies were negative is because of hugely unrealistic expectations of the benefit. Most of these studies constructed their study in a way that they can demonstrate a 10% reduction in mortality, though most of the observed mortality differences were much lower, closer to about 2.5 to 3% in contrast to 10%. So these studies were unfortunately a little too small for the detection of what they see as a genuine reduction in the mortality. And this is quite important because this creates another problem with Delta, not with the Delta virus, but what we would call as Delta or the treatment effect. The magnitude of the treatment effect determines the size of the study that is going to be used in a randomized controlled trial. If you're going to detect a large treatment effect, you can probably be very happy with a small trial. And one way in which many authors seem to be making these estimates is basically on rough data. And very typically, it is seen that when authors are dealing with death-related outcomes, they exaggerate the benefits on mortality of that treatment. And they probably also underestimate or really basically make the control group look very bad, exaggerating this delta or the difference or the mortality or the magnitude of the treatment effect is inflated. This is what is called as delta inflation. And this has been very well documented in critical care literature. This paper, again, from Intensive Care Medicine in 2013, showed that in 11 trials in Intensive Care Medicine journal, which had death as an endpoint, okay, 7 of them inflated the delta. Or in other words, in these 7, you notice that the predicted delta is significantly higher values than the observed delta. Okay, and this is quite important for us to recognize why many of these trials are basically negative trials. I think before we jump onto the bandwagon and basically decry all these interventions that are genuinely effective, we need to understand that Delta is not only a threat to human lives in the form of the coronavirus, but Delta inflation is a genuine threat to the randomized controlled trial. And there is a huge need for an improvement in the quality of the randomized controlled trials. And I'm pretty certain that as these improve, that some of these treatments that we have sort of rejected during the course of these short discussions will probably be reinstated. Thank you very much for listening. And I hope I didn't create huge amount of controversy by talking about this aspect of poor quality of our randomized controlled trials. Thank you very much.